Intussusception is the most common abdominal emergency in young children, and it can be a challenge to figure out who just has an early gastro, who is just fussy and crying, and who might actually have something more serious going on. So basically, this is definitely one of those needle in the haystack issues that we have so commonly in peds emerge. And the other problem with intussusception is that it doesn't always present like they describe it in the textbooks, so we have to really keep our antenna up for it. The most common type of intussusception is the idiopathic form that involves the ileocecal valve, so the small bowels going through the valve and getting stuck in the large bowel. And 80% of cases occur in babies and toddlers under the age of 2, with the incidence peaking around 9 to 10 months. Less commonly, intussusception can occur in older kids, and in these cases, it's more associated with a pathologic lead point. So they have an underlying Henoch-Schönlein purpura, or they have a Meckel's diverticulum or a cyst, or something else in the bowel that serves as a lead point. So as I mentioned, the presentation is a bit variable, and that's what makes it really tough. So they do describe this classic triad of intermittent abdominal pain, vomiting, and bloody stool. But, to be honest, I've never seen a kid with the bloody stool. And when you look at this classic triad, it's way less than half the kids. So not super helpful. Other authors describe the waves of pain and the paroxysms of crying every sort of 15 to 20 minutes. And certainly I've seen many kids that it's not as frequent as that. So I think we have to be careful not to hang our hat completely on that frequency. The vomiting can occur during those paroxysms of crying or with the painful episodes and can progress to bilious emesis over time because it's an obstruction. The other thing is that a baby can present with just decreased LOC. So intussusception is on the differential for a baby or young child who's just altered. And as I mentioned, the current jelly stool that we all learned about in med school is a late finding. And despite having diagnosed intussusception many times, I have never seen current jelly stool. So it is definitely not a diagnostic requirement. Rarely, you might actually palpate a mass on the right side of the belly. In fact, one time I had a toddler who'd had a couple episodes of crying. She was having some pain and pulling up her knees, and she'd had a couple of episodes of vomiting, but she looked really well when I went in to see her. And then the dad said, I think the right side of her belly looks bigger. And he was right. So lucky for me. So, basically, I think you need to think about intussusception in the right age of child. So babies and young children, right? Babies and toddlers. And they can present with a constellation of symptoms. So vomiting in the absence of diarrhea, and it might be bilious. They could have recurrent crying episodes that aren't normal for them. So good to ask the parents about their behavior. They could have episodes where they seem to have pain in their belly. They might even pull up their knees. So good to ask about that to the parents. They could just look pale. They could have a decreased LOC or the bloody stool. And any of those symptoms alone or in combination with the right age of child should add to our index of suspicion that there's something other than just an early gastro going on. When you're doing the physical exam, you're going to want to try and get them as calm as possible and assess their belly. And you might need to come back and do it. You might need to give them some pain control and come back and assess. But if it seems persistently tender or you feel a mass, they're definitely going to need a workup because, in gastro, the belly is not usually that sore and they're usually quite distractible. If there's no worrisome features on the history and they have a perfectly normal exam, so, they're not having episodes of crying, they don't seem to have pain, there's a bit of vomiting, but there's no signs of obstruction, kid looks really well for you, totally normal exam, able to tolerate fluids for you, then I think you're good to discharge them home with good instructions. Like, obviously, if the vomiting recurs and persists, if it's bilious or bloody, if they have bloody stool, if they seem to have worsening belly pain or lethargy, then they're gonna have to come back. And if they do have any of those historical features that we talked about, or they have significant tenderness or a mass on the belly exam, they're going to need a workup. And that basically means that they're going to need an ultrasound. So the sensitivity and specificity of the formal ultrasound is essentially 100%. So you get the classic sort of target or bullseye lesion, and that's just the layers of intestine within intestine. And POCUS is great for intussusception as well. X-rays are much less sensitive and specific, so they shouldn't be used routinely unless you think the kid has a peritonitis or perforation. You could see obstruction or absence of colonic gas or a target sign on the right kidney in the X-ray, but they can also be normal even when intussusception is present, so not super helpful. We generally do start IVs in these kids and give them some fluid. You might need to bolus if you're worried about hyperperfusion or shock, and we need to treat their pain. So starting with the acetaminophen and ibuprofen, and then you can progress to opioids intravenously if the pain seems like moderate or severe. We give empiric antibiotics like ceftriaxone and metronidazole if we're worried about perforation or peritonitis, but otherwise you should not give. As long as there's no concern for perforation, the child goes on to air enema reduction. That's under fluoro or ultrasound guidance, and it's successful like 80 to 90% of the time. And it's usually done by the peds radiologist with peds surgery available, since perforation is a rare complication of the air enema. It can be repeated if it's initially not successful, as long as there's no perforation, the child's tolerating it. But otherwise, if it is not successful, the child will go on to laparotomy. If the reduction is successful with the air enema, the child can be observed in emerge for about 4 hours, and then they can be discharged home if they're well and they're able to tolerate oral. And that's great, actually, because we used to admit all these patients to hospital. There's about a 2% risk of recurrence within those first 4 hours post-reduction, and then about a 10% overall risk of recurrence for kids with intussusception. But they can go home with normal care, no restrictions, and good discharge instructions about coming back if the abdominal pain seems to come back, if they have vomiting or lethargy. And if there is a recurrence, they can still be reduced using an air enema. But kids who have multiple recurrences usually do get worked up to rule out a possible pathologic lead point.